didactic blitz. So I promise Jamie that this is not going to be, it won't go incredibly long. There are a number of things that are in here that are really just for your reference, that you can go back and look at a little bit later that might be helpful. So my objectives, what I hope to accomplish quickly, is to look at the variety of indications that we have for antipsychotic medications, because that really is diversified quite a bit. We're going to compare how they work. So pharmacologically, so the way that the drug works in the body, why they're different and we have separate classes. And then we're going to look at some of the side effects that we do need to be cognizant of and be monitoring for in patients who are on antipsychotics. So I wanted to start at the beginning. I wasn't sure exactly how to, I didn't want to jump right in. So antipsychotics, chlorpromazine was the first one that was developed. It was actually developed because they were looking for antihistamine anesthetics. So something that was going to be sedative that they could use during anesthesia. And they found that it could be really helpful in patients who were agitated or had other behavioral problems. As they continued to use this in patients that had a number of mental illnesses, they began to describe it as a neuroleptic, which meant to take hold of one's nerves, because it seemed to really help patients that had been experiencing other mental illnesses where we really didn't have anything else that would be beneficial for them. So as that terminology started up, the first class of antipsychotics, so they used the chlorpromazine and started just making some minor changes to that particular drug structure. And it emerged as antipsychotics. They call them neuroleptics. And as we started to get newer ones that worked a little different, you started hearing things like first generation or typical or classical antipsychotics. I'm going to use first generation, second generation, because I think that helps create a little bit of a clearer divide, but that's where some of those descriptors came from. We've had a number of them. Most of them work in a very similar way, but because they're all slightly different, you can think of them almost like cousins, so related but not necessarily identical twins. We need a way to compare them. So one of the ways that we compare them is using chlorpromazine equivalent dosing. So chlorpromazine was our first, so that's the one that we actually use to say, okay, about this much of one medication is about this much of another medication, because for some of them we're using smaller doses, 6 milligrams, 4 milligrams, and in other cases we're using hundreds, 300, 400, 500 milligrams. So this gives us a way to be able to speak the same language. That comparison language has changed recently. Over the last about 5 years, they've been looking for other comparisons, but this one is the traditional one. So that's the one I did include. So the way that these early antipsychotics act, and the way all of our antipsychotics act to some extent, is by blocking one of our neurotransmitters, so dopamine, specifically the dopamine 2 receptor, and we're going to look at that in just a second. But within this early class, there also was another differentiation, and we'll talk about that here. So this was my rendering. It looks very much, so there are some psychopharmacology textbooks. I have actually 2 of them on my table right now, but this was one I created, so there's no copyright issues. With the FGA being our first generation antipsychotic, it doesn't just work on dopamine, but one of its main antipsychotic actions is by blocking this dopamine receptor. Now, why that's important and why that's helpful is that it's thought that for psychosis, there's too much dopamine in certain tracts of the brain. So if we're able to block the actions of extra dopamine, then we can actually help with some of the psychosis, the paranoia, the disorganization. They didn't just block dopamine, they have a few other actions. So acetylcholine, histamine, as well as norepinephrine are those other receptors that you see sitting on the top there. And those receptors are responsible for some of the adverse effects that we see. So with this older class of medicines, our high potency were agents where the dopamine action was really potent. So it didn't take many milligrams to be able to block those dopamine receptors. The low potency, they had a lot more activity at those other receptors, and we needed much higher doses to get the block on the dopamine that we were looking for. So here's just a list of our first generation antipsychotics as well as their brand names. In some cases, the brand names are no longer available, but just from a perception standpoint. So you have something to look at, because sometimes it might be a little bit more obvious. People know that they've heard of thorazine, but they may not know what the generic name is. Mm-hmm. And with this class, there's quite a few different indications, so things that we've used this for. So I included both the FDA-approved indications as well as some of the documented non-approved uses. And I think the main take-home point I want you to, I promise, Jamie, I won't go through all of this. The main thing I want you to take away from this is it's really diversified. So while we were looking at the treatment of psychosis and schizophrenia, we really started to see a lot more indication. So for things such as Tourette's syndrome, for bipolar disorder, for some problematic behaviors in behavioral syndrome. So when individuals are acting out and they need medication in order to help bring that under control. Borderline personality disorder shows up there. It is used, the evidence isn't great for it, as well as some other indications that it doesn't have a ton of use, but you may occasionally see it being used. So anxiety disorders, anorexia, as well as for Huntington's disease. So just because we see an antipsychotic, it doesn't mean that the patient automatically has to have schizophrenia. There might be a number of other things. Actually, your little tidbit of trivia today, chlorpromazine is used for intractable hiccups. So patients that have hiccups and they can't get rid of them, that would be the treatment. Because they are high and low potency, this just gives you an idea of which ones fall into that category. And as you think about agents that you've probably seen used more frequently during clinical practice, the high potency ones tend to be the ones that we've used most frequently recently. So fluphenazine, haloperidol tend to be ones that are used pretty commonly, especially because they also are available in long-acting injections. So we really were looking to block those dopamine receptors. And when we block those dopamine receptors, we can end up with side effects. So these side effects are mainly due to some of those other activities. So histamine, acetylcholine, as well as norepinephrine, it can work on your alertness. It works in your GI tract, so it'll help dry things up. So we often see things like blurred vision, dry mouth, constipation. It can cause some cognitive dysfunction in patients, especially older patients. But with the and this is by no means a complete side effect list, but because of that tight dopamine blockade that we were trying to accomplish, dopamine works in other parts of the brain. It's intimately involved in movements. We started to see a lot of movement disorders. And this was one of the things that was most problematic with our older agents of antipsychotics. So there's 4 different types of movement disorders. I'm going to go through them quickly, but know that they occur at different times. So with dystonic reactions occurring first, akathisia and Parkinsonism, we see kind of after patients have been on the medicine for a little bit of time, and then dyskinesias we worry about after they've been on, especially tardive dyskinesia, which wouldn't go away after they've been on medication for a while. So dystonic reactions are like muscle contractions, almost like you have a muscle cramp. So I think one of the best examples that I had heard was imagine trying to touch your chin to one of your shoulders and also touch the back of your head to your other shoulder, but you're not doing it on purpose, it just occurs to you. And that can happen very quickly, very suddenly after either the medication is introduced or the dose is increased. And that could be a reason why a patient does not want to be back on that medication, especially if it's relatively severe. So we can treat that with some of our anticholinergic medications, but if we can prevent them and have patients on medications that don't cause it or low enough doses, we would ideally like to do that. Akathisia is one that really hasn't gone away. We're going to talk about some of these aren't quite as common, but akathisia is restlessness. And sometimes that can look like agitation from either the bipolar disorder, the schizophrenia, whatever the patient is experiencing. And that's something we need to make sure that we keep in mind, because it's not always as clear. They may be movement restless, they just may be internally restless, where they just aren't comfortable in maybe they're not moving around quite as much as we would think, but they're just really restless and a little bit irritable and on edge. The last two, so pseudo-Parkinsonism, so it blocks dopamine receptors. Parkinson's disease is a disease where dopamine neurons are degenerated. So this makes the body look like it has Parkinson's. So they may be slower in their movements, they may develop a tremor, they have a stooped posture, they may be a little more unsteady on their feet. And again, we could treat this with medication, but ideally if we can get the dose down to not cause those side effects, but still control the reason that we started the antipsychotic, that would be ideal. The main kicker for the movement disorders that most people think of with the antipsychotics are the dyskinesias. So these are movements that patients are making that they're not doing on purpose. They can be anywhere in the body. They very often do show up in the face. And unfortunately, the higher the dose, the longer a patient's on it, these may be irreversible. So they may never go away. So now you have a patient who has a mental illness that may stigmatize them a little bit, and they have movement, so it makes it even more obvious that they were on medications, which can be really problematic. And in some cases, it can be really functionally impairing, especially if it affects their throat at all for eating, swallowing, chewing, those kind of things. So that was why we needed different types of antipsychotics, and that's where our second generations came in. You may also hear them referred to as atypical antipsychotics. Some people claim there's a third generation. I am not going to identify a third generation, and we'll talk about why in just a couple minutes. So the goal for this really was to have good efficacy and better tolerability for patients that needed antipsychotics. And they diversified how it worked. So we realized that, you know what, we can't just block all the dopamine because it doesn't work for everybody anyways. What else could we use that would be beneficial? That's where we got some serotonin, another neurotransmitter. And they were also hopeful that by adding the serotonin in, that we would get some additional efficacy for both negative symptoms of psychosis as well as some of the cognitive symptoms. So for the second generations, in general, they still block the dopamine receptors a little bit. There's a handful of them that are actually partial agonists. So at our receptor, we have a substrate. So that's what turns it on. We have antagonists, which block it, so we get no activity there. The partial agonist isn't going to turn on the receptor as much as the dopamine would, so it will block a little bit, but there's more dopamine activity than there would be if it was just being blocked by an antagonist. So it's almost like a dimmer switch, where the dopamine would have the light on, the antipsychotic, like our haloperidol, would have the light off. Our partial agonist, which aripiprazole is one of them, would be kind of the mood lighting that's there in the middle. Now, yes, that is slightly different, but from an efficacy standpoint, we haven't seen a significant difference that would distinguish this as something completely different. So they still do get lumped together into this group overall. The new action that was added on board is we block some of the serotonin receptors, so specifically the serotonin 2A receptor. Now, dopamine neurons and serotonin neurons, it's not only dopamine works on this set of nerves. And what they found was if we block this serotonin neuron, we actually can get some dopamine released in other areas of the brain, which seems to help with movement disorders, and they were hoping was really going to help with some of the cognition and the other adverse effects that we saw. For the record, this is just a generalization. Most of the medications also have other activities, but I was given a limited period of time, so these are the big ones. Here's your list of new agents. The Nuplazid that's on there really is used not necessarily for treatment of schizophrenia, so they're using it for psychosis, but in patients who have Parkinson's disease. So I'm just going to set that one aside because even though it works similarly, that one's a little different than where we use the rest of these agents. Here's your indications. I had to break these down by class. So instead of high potency, low potency, we have some that have relatively similar chemicals that they work on. So your pene group, clozapine, olanzapine, quetiapine, asenapine, your azoles, so aripiprazole and brexpiprazole, these are two of the agents that are those partial agonists. So they don't completely block dopamine, but they do tone it down a little bit. Our dones that are here at the top, risperidone, ziprasidone, paliperidone, lurasidone, iloperidone. And I put risperidone on there twice. I wanted to make sure you didn't miss it. Sorry about that. And then cariprazine also is one of the partial agonists. That one works a little bit differently, but still relatively consistent with what we see in this class. And lumateperone is actually our newest agent that we'll be launching here shortly. So it works on serotonin and dopamine, but most of its activity is actually with blocking the serotonin receptor. So starting to move that balance a little bit away from the dopamine. So does that help in side effects? Some, it does some. We still see a lot of the adverse effects that we saw with the first generation. So constipation, dizziness, dry mouth, orthostatic hypotension where their blood pressure drops if they stand up, and they might get a little dizzy, and sedation. But the big thing that arrived with this new class of medications are those metabolic adverse effects. So we can see weight gain, we can see rises in both blood glucose as well as cholesterol levels. So putting patients at risk for diabetes and cardiovascular disease. It doesn't cause the movement disorders as much, but it still can happen. So we do still have to watch for those. And all of the antipsychotics actually can cause some cardiac changes, potentially setting patients up for a cardiac arrhythmia. There are some in specifically ziprasidone in the newer class that were really identified as being most likely to do it, although almost all of them actually have been documented to show some of those changes and potentially put patients at risk for the arrhythmias. So something we want to think about if patients have any heart problems. The other warning that goes for all of the antipsychotics is in elderly patients who have dementia. Sometimes they're acting out, and we previously had used antipsychotics, but in patients who have dementia that are on antipsychotics, they actually have a higher mortality rate. The deaths are usually due to cardiovascular or an infectious cause, but we need to really be careful and mindful justifying why we're using an antipsychotic in this population. To tie everything up, as we look at them, there are lots of choices, but for the most part, they're equally effective, with the exception of clozapine, which seems to work best for patients who didn't respond to other antipsychotics. Most of them are pretty consistent in how effective they are at treating those symptoms. This was in patients who had schizophrenia or schizophrenia spectrum disorders. And despite having the equal efficacy, patients tolerate the medications very differently. So the CATIE study is a little bit dated now, but it was a really good opportunity to look at how do patients do when they're on both first and second generation antipsychotics. The olanzapine group actually was one that was least likely to be discontinued, despite the fact that it does have quite a few of those adverse effects, including those metabolic adverse effects. So something to think about is it needs to be patient specific. What adverse effects are they willing to tolerate? We can't predict which patients get them. So even in medications that aren't supposed to cause a lot of weight gain, we may still see some weight gain. So we do want to keep that in mind. Overall, from a tolerability standpoint, there are some that are better tolerated. So the olanzapine stays on that side. Clozapine, even though we need some blood draws with that one. But it doesn't mean we can't use those other medications. It just means that we want to make sure that we're checking in with patients, not only when they started, but when they've continued on antipsychotics, to make sure they're not still having side effects that make it problematic for them to keep taking it. So in summary, our antipsychotics, we've got a big class of medications that we can choose from. Their efficacy is generally similar with the one exception of clozapine. Side effects are a significant problem with all of them and something we need to monitor as long as patients are on it. Movement disorders, bigger problem with the older agents, but still something we got to keep track of with the newer agents. And there's a lot of variability in between patients who are taking these medications.